So who gets the plastic? This is such a tough clinical decision. When do you need to intubate? And I think the most important thing that we need to take away, the important thing to realize in dealing with the sick asthmatic, is that intubation solves no problems. It does not treat any aspect of asthma. It simply is buying you time for all of those medicines to work. It's taking away that work of breathing. So it makes sense that maybe, we don't want to intubate prematurely. Maybe there's an alternative, and non-invasive positive pressure ventilation is absolutely that alternative. And you really should consider this, BiPAP or CPAP. BiPAP has maybe a little bit better outcomes, but really both are probably equivalent. So basically we use BiPAP or CPAP to take away that work of breathing for the patient, give them time for those steroids to kick in, give them time to kind of help them breathing, help them not tire out, help those continuous nebulized beta agonists to get in to work.
Is it just me? Can you click back there to the last slide?
I'm sorry?
Does that kid look like Luke Skywalker from the first Star Wars movie? Like
maybe it is.
Red leader.
Yeah.
I think he's about to blow up the Death Star there.
He is. Yeah, it doesn't necessarily look comfortable. And we have a whole lecture on non-invasive positive pressure ventilation, some tips and tricks and settings in another section. So what happens now? Going back to this situation. So we've given continuous albuterol. We've given 3 doses of Atrovent. We've given MAG. We've given steroids. We've given IV fluids. We've tried the ketamine. We have the patient on non-invasive positive pressure ventilation. When do we make that call? When do we decide to intubate that patient? And this is such a tough clinical decision. It really is. You want to intubate the patient that is having continued progression to respiratory failure despite everything that you know how to do, despite that maximal therapy. And that is a tough, tough call. You want to wait, give them time, give them a chance to not be intubated, because intubation certainly has a lot of risks, inherent risks and problems, but you also don't want them to totally poop out and code. So it's a really, really tough call. A couple words on ventilator management. You can have problems with barotrauma even when you're not on the ventilator. So you have hyperexpansion, you're blowing air in, and then you have risk of barotrauma, pneumothorax, pneumomediastinum, pop a lung. That can be life-threatening to a patient. So you have to remember a few things. You want to decrease the respiratory rate, decrease the tidal volume, and decrease the inspiratory to expiratory ratio. Get it 1 to 3 to 4. Give them time to exhale that trapped air. This is going to result in high CO2s, and they're going to become acidotic. But they are going to tolerate being acidotic much better than the complications of barotrauma. So these are just criteria that you're just going to have to accept. You want to keep your plateau pressure, a surrogate marker of barotrauma, less than 30 centimeters of water. This is something that your RT can check for you on the vent. Let's say you have made that decision, made that tough call to intubate this patient. They're on the ventilator. You're doing everything that you know how to do. What do we do next? Do we have other options? There are a couple of options. You can give the anesthesiology a call and think about doing inhaled anesthetics because these do have some bronchodilatory properties as well. ECMO is certainly a consideration if you have the capability in your facility or could potentially transfer a kid to a facility with ECMO, because these kids are typically otherwise healthy. They just need to get through. You need to breathe for them without their lungs, and ECMO definitely is a helpful consideration. What do you do in that situation, unfortunately, when you've done everything and that patient dies in front of you? There's a few things before you call the code in that unfortunate situation. There's a few things that you absolutely have to do, because you have hyperinflation of the lungs, you have gastric distension, risk for attention pneumothorax, all of these things. You have significant increased thoracic pressure, which results in a decreased venous return. So if you have a patient with asthma that arrests on you, you need to do several things. You need to disconnect that ventilator and give them a trial period of apnea If you bag at all, slowly bag. Give them time for that thoracic pressure to decrease, that air to get out, and that venous return. You want to give them an IV fluid bolus to help kind of boost up or bump up that venous return. You want to manually compress their chest to help squeeze that air out. And at least do a bilateral needle, if not place a chest tube, because you don't want a patient to die of a tension pneumothorax without some intervention. So that's all I have on asthma.
You've scared me.
I know, right? Yeah.
As
it's
far as
very stressful.
It's
very,
one of
very
those things where, so I just want to ask a quick question, like what's your algorithm as far as your approach? You have a person coming in with asthma. We all know about the albuterol Atrovent, give them the steroids. At what point are you giving the IV fluid bolus and the magnesium? When are you actually starting an IV on them? I mean, is it after 3 rounds it hasn't responded, and then you're going to say, okay, we need to amp it up because things aren't going the right direction? Is that when you do it? Or do you just empirically start the IV?
It's kind of a tough call. Like if somebody, it depends on how quickly, their symptoms came up. If they're looking absolutely terrible, I'm doing obviously more. My pace is matching the progression of their disease. But I'll start a treatment. I'm like, okay, let's just put 3 treatments, albuterol, Atrovent in right now. Let me watch them, and if they're seeming to do a little bit better, okay, then I'll hold off. I mean, I've many times given a kid, over an hour or 2, like 6 treatments. Haven't done an IV. If they're really responding, really turning around. But if they're not responding, you can kind of tell after you've given a few treatments.
Right. I was going to say
20 minutes.
Like sometimes for me, it's the starting point. Like if they come in, they're diaphoretic, they look like they're having that doom kind of look.
Sure. The kitchen sink goes to them.
Then they get everything rapidly.
Absolutely. Then you want the IV steroids
they're getting terbutaline. They're getting I will be very aggressive early on. Or if they have a history that's concerning, like they've been in the PICU and intubated several times, or the worst case scenario is those kids that don't have frequent attacks, but when they do,
it's terrible.
Always get sick. Those are the kids that die.
Yep, absolutely. And even, a fair number, a significant percentage, I forget offhand what it is, but patients that actually die with asthma don't have risk factors for that. So,
because they're the
can
infrequent,
be tricked.
severe
you just,
characters.
you treat what's in front of you. And you pull the trigger quickly. If they're not responding to treatments, you go harder.
Sounds good. Cool. Thanks.
This is Hippo Education.